Good afternoon, everyone. My name is Maeve Williams, and I am a project manager at the North Dakota State University Center for Immunization Research and Education. Today, I have the pleasure to introduce Dr. Tracie Newman, who will be presenting this webinar titled Science to Practice: Protecting Children from Respiratory Viruses in 2025 to 2026. Dr. Newman is a board-certified pediatrician and previously served as health officer of the city of Fargo. At North Dakota State University, she is an associate professor of practice in the Department of Public Health and the medical director of the Center for Immunization Research and Education. She is also an associate clinical professor at the University of North Dakota School of Medicine. Dr. Newman received her medical training at the University of North Dakota and completed a pediatrics residency and obtained a Master of Public Health degree at the University of Minnesota. She is an elected member to the Executive Committee and serves as policy chair for the Council on School Health for the American Academy of Pediatrics. Dr. Newman, you can begin.
Thank you, May, for that introduction. Hello, everyone, and thank you for joining me and Siri today. I'm excited to discuss a topic that's important to all of us in healthcare, protecting our kids from respiratory viruses in 25-26 season. I'm looking forward to diving into the latest science and trying to translate that into practical strategies that we can use to care for our youngest patients this fall and winter. So this is a standard disclosure sign and CME slide. I have no financial disclosures. We will be discussing off-label use of medications in this presentation, primarily referencing COVID-19 vaccination recommendations outside of FDA-approved use. Today, we will provide an overview of current and emerging trends in pediatric respiratory viruses for this upcoming respiratory season, with a focus on RSV, flu, and COVID. We will highlight some risk factors and certain pediatric populations that are at more risk for experiencing severe outcomes, and then end by reviewing the data for our current prevention options for these respiratory viruses and some of their evolving guidelines. So to set the stage, if you're anything like me and some colleagues I've spoken to, there's sort of this overwhelming sense of just what is happening. This is a landscape that is confusing, I think, for the public and providers alike. Professional organizations like ACOG and the American Academy of Pediatrics are now openly breaking with the CDC by continuing to recommend COVID vaccination for children and pregnant people, even after federal agencies have rolled back or halted their recommendations. I think, this split really underscores how in today's turbulent environment, medical groups are leaning on scientific evidence to guide their decision-making and recommendations, while government decisions appear increasingly shaped by politics rather than established processes. So as an example of our typical process, this kind of depicts how vaccines are developed, approved, and then finally made available to the public in the United States. So you can see this is a multi-step process. It involves several agencies and stakeholders to ensure safety and effectiveness and accessibility. So each year, experts from the FDA and the World Health Organization analyze global data to predict which strains of virus, so for example, influenza or COVID, are most likely to circulate. They recommend a vaccine formula to match those strains. So once the formula is decided, vaccine manufacturers begin production. This can take several months because of the complexity of vaccine development. The Advisory Committee on Immunization Practices, or ACIP, then reviews evidence and makes recommendations about which group should receive the vaccine. So should it be children, older adults, people with chronic conditions? They kind of decide the who. And then the recommendations are reviewed and signed off by the Secretary of Health and Human Services and the CDC director to become official policy. From there, insurance providers, both public and private, decide on coverage policies. So this ensures that vaccines are accessible and affordable for patients. Healthcare clinics and hospitals and providers then place their orders so they're ready to vaccinate patients once these doses become available. Before distribution, the FDA provides formal licensure and approval, confirming that the vaccine kind of meets all the safety and efficacy standards. And then finally, vaccines are distributed, right? So they become available to different entities and shots go into arms. So this entire process is designed to balance speed with safety. It ensures vaccines are carefully vetted while also being available in time for seasonal outbreaks like flu or COVID season. This highlights how the vaccine recommendation process has changed in 2025 compared to what normally happened. This is highlighting some key differences using COVID-19 vaccines as an example. So, step one is unchanged. The FDA and WHO still determine the fall vaccine formula based on circulating strains. Manufacturers continue to produce vaccine once that formula is set. So, there was no major change here. Step three is where we see the first major disruption. Traditionally, the ACIP decides who should get the vaccine. In 2025, ACIP's authority has been stripped. RFK Jr. replaced the entire advisory group, adding many vaccine skeptics, and that's continuing into even this week, as in a few days ago. He also dissolved many expert advisory groups that assisted the ACIP. Importantly, this new group didn't vote on COVID-19 vaccines in their last meeting. Then the step where the HHS secretary and CDC director review and sign off on recommendations has been removed in 2025. Insurance decisions still happen, but without ACIP and HHS guidance, there's just less clarity on who is officially recommended to receive the vaccine. Clinics can order vaccines, but COVID-19 vaccines are stuck earlier in the process, so they aren't making it this far. The FDA does still provide licensure, but with restrictions. So in 2025, the FDA has limited COVID-19 vaccines to high-risk groups only, especially under age 65. And there's also some inconsistency here. So RFK Jr.'s group excluded pregnant women, while the CDC continues to classify them at high risk. So because of these changes, COVID-19 vaccines have not reached the final step, that stage of widespread public access. And it's unclear if ACIP will continue to meet or vote on COVID-19, although it is on the agenda for their upcoming meeting. And importantly, I think to note too, all professional organizations have been removed from this process as well. So this is just an immunization guide for this coming fall and winter respiratory viruses. This is here for your reference. We tried to group a summary for you. You can see each virus and the vaccine. It's broken down by population or age group, and then what certain groups are recommending what. The big unknown is down at the bottom corner there. That remains healthy adults for under the age 65 and the COVID vaccine. ACIP is actually supposed to meet next on September 18th, so very shortly, and we should know more then. From there, it's anticipated multiple forthcoming recommendations from various groups as well. But specifically comparing recommendations for pediatric population, so RSV and flu, the AAP essentially mirrors CDC guidance supporting early infant RSV immunization and annual flu shots from 6 months onward. COVID-19 is where the two diverge rather sharply. AAP explicitly recommends COVID-19 vaccination for all children ages 6 to 23 months and strongly recommends it for older children at higher risk, while allowing other parents to opt in. CDC has stepped back from this universal recommendation, instead urging a shared decision-making approach between parents and providers for all children, so 6 months to 17 years. So we've seen alternate groups kind of step into this space to review evidence and make recommendation. This is the CIDRAP's Vaccine Integrity Project. It's an initiative dedicated to safeguarding vaccine use in the United States. They say it remains grounded in the best available evidence, free from external influence, and focusing on optimizing protection of individuals, families, and communities against vaccine-preventable diseases. So this is led by Dr. Mike Osterholm out of the U of M. Siri has been a collaborator with them on various things. You know, I think outside of medical organizations, many experts think it will be important for groups like this from academia or even the private sector to really organize and come out and make vaccine recommendations as well. A poll by Harvard School of Public Health and the De Beaumont Foundation in June of this year found that most US adults, around 79%, say parents should be required to have children vaccinated against preventable diseases like measles, mumps, and rubella to attend school. So this includes a majority of adults across party lines, which was interesting, 90% among Democrats and 68% among Republicans, as well as even 66% of those who say they support the Make America Great Again movement. Major reasons for supporting vaccine requirements for school included things like vaccine effectiveness, family responsibilities to keep schools healthy, and then the concern that diseases like measles could return without such requirements. So alternatively, now that means among all US adults, about 1 in 5 or 21% do not support routine childhood vaccine requirements. The most common reason for opposing these is parental choice, not a concern about safety. So during these times of change and seemingly moving backward, I think it's important for you to remember that you are your patient's most trusted source of vaccine information. Studies have repeatedly shown that Americans trust their doctors, their individual providers, more than any governing body or professional organization, particularly when it comes to vaccines, but also other health information. Additionally, past Gallup polls have continued to show that nurses rank the highest among professions with the greatest honesty and integrity. Pharmacists actually rank quite high as well. So creating a unified message about vaccines from the whole care team, I think, is really critical in promoting trust for things like vaccines. This is data from August of this year highlighting some of that. So while we've seen trust in government entities like the CDC and even local and state health departments decline in recent years, people still really do trust their individual providers, particularly about vaccines. So despite how it might feel in your day-to-day practice, we know that about 80% of Americans continue to report a great deal or fair amount of trust in their doctor. Okay, so for an overall perspective, let's look at respiratory virus trends in the United States. So during last year's respiratory season, this is for children 4 and under, you can see RSV far predominated when compared to flu and COVID for bringing kids into the hospital. The combined rate of having one or more of these viruses is the highest and quite high for all, but in older school age kids, we see now influenza have the highest rate of hospitalization. Again, combined viruses is high. RSV is still a factor here, but not nearly as much as flu. And I would just note that this graph has a different scale when compared to the last graph. So the overall hospitalization rates in this age group are lower, but just to highlight that flu is the biggest player. And the same holds true for older adolescents. It's influenza again. Here we see RSV much less. And our 12 to 17-year-olds have the lowest hospitalization rate of the 3 age groups. And you can see that rates of RSV and COVID hospitalization are much more similar than in the other age groups. So how were our vaccine rates in this country last season? As of late April of this year, only 13% of children were up to date with the COVID-19 vaccine. Almost 30% of infants were protected from RSV, either by getting nirsevimab or through maternal vaccination during pregnancy. Not bad, given that that was the first season that some of these products were available and there was some initial supply issues. But nearly half of our children received a flu vaccine, much more than the other two you can see, but I would note that is actually lower than the same time point the year before that. Okay, so that was kind of a brief overview. We'll now walk through each virus, starting with influenza. The 2024-25 flu season was particularly bad for all ages, including kids. Among all populations from October 1 of 24 to mid-May of 25, there was an estimated 47 to 82 million flu illnesses, 21 to 37 million doctor visits for the flu, upwards of 1.3 flu hospitalizations, and anywhere from 27,000 to 130,000 deaths attributed to influenza. This pediatric flu death for the last season were especially high, the highest it's been in 15 years. We know this virus is common in our kids every season, and while many people brush off the flu as just another cold to get over, it can be very serious in children. hospitalization rates are highest in kids under 5, particularly high in infants less than 6 months old. As many as 10% of all pediatric hospitalizations during the winter are attributable to influenza. And we know viral infections can have secondary sequelae in kids. Anywhere from 8 to 11% of children that are hospitalized for flu experience some sort of neurologic complication. Flu hospitalizations have risen in the past 4 flu seasons in both younger and older kids. And again, they were particularly high this past season. While having an underlying medical condition increases your risk for more severe disease, interestingly, almost half of pediatric flu hospitalizations were otherwise healthy kids with no known health conditions. For those who did have something, asthma was the most common, followed by neurologic diseases and obesity. There are other complications from flu, not just hospitalizations. We saw increased amounts and actually case clusters of this acute necrotizing encephalopathy. So this is a severe form of influenza associated with encephalopathy or encephalitis, where you see rapid neurologic deterioration and many parts of the brain can be affected. So over the past 2 respiratory viral seasons, we saw 41 cases of this in kids, which is higher than pediatric neurologists are used to seeing. 76% occurred in otherwise healthy children. And of those that survived that, 63% had moderate to severe disability even at 3 months follow-up. And this carried a 27% mortality rate. All but one of the deaths that occurred were in unvaccinated children. Sadly, last flu season, we saw 275 pediatric flu deaths. Again, that's the highest number in many years since the 2009-2010 season. Of the 275 children who died last season, 90% were unvaccinated, and we believe any number of vaccine preventable disease deaths is one too many. So let's look at influenza vaccine for kids. As we said, everyone 6 months and older is recommended to get a flu shot annually. Kids under 9 who have not received 2 lifetime doses will need 2 doses this season, administered 1 month apart. This is just a visual pathway to walk you through that. Generally, it's recommended for kids to receive the flu vaccine before the end of October in order to provide the most protection at the most critical time. However, people should still be vaccinated later in the season as well, as we know this still provides protection and can cover you later in the spring. And keep in mind that the flu vaccine takes around 2 weeks it takes you about 2 weeks to mount antibodies and maximum protection after getting vaccinated. Those who are pregnant are advised to receive the flu vaccine, only the injectable form, so no flu mist or live virus vaccine. And there's actually a new option this season for people ages 2 to 49 years. You can order nasal flu vaccine to your home for self-administration. A note about thimerosal. This has been in the headlines recently. So this has been in vaccines since the 1930s. It is used as a preservative in multi-dose vials to prevent contamination. As kids were getting more and more vaccines containing thimerosal, there rose a concern that children were getting too much mercury from vaccines. Studies have been done which show that you are at no greater risk if you receive a thimerosal containing vaccine than if you don't. They've also looked at if there was neurodevelopmental harm because mercury at high levels can cause damage to the brain. Since thimerosal is ethyl mercury, it's excreted from the body very quickly. So there's no harm found from vaccines containing this as a preservative. Anti-vaccine groups have jumped on this platform to claim that thimerosal was causing autism. Studies have repeatedly shown that thimerosal-containing vaccines do not cause autism or any neurologic harm. So despite this history, in June of this year, the new ACIP recommended that children and adults only receive flu vaccines in single-dose formulations, which are free of thimerosal. I would note it is the AAP stance that children should receive any available formulation rather than delaying vaccination in order to wait for a non-thimerosal containing vaccine. And I would also point out that only about 4% of flu vaccines in the United States contain thimerosal. So we have data from large studies conducted in over 38 countries involving more than 6.5 million patients, indicating that being vaccinated reduces your risk of death from severe flu by 3 to 4 times. And it is true that the effectiveness of the flu vaccine varies from year to year. It's generally between 40 to 60%, depending on the match between circulating strains and the vaccine formulation. But even in years with suboptimal matches, the vaccine significantly reduces the risk for severe outcomes, including things like needing to come into the hospital, ICU admission, and death. In the 2023-24 flu season alone, which had a fairly low effectiveness, it was about 44%, we had substantial reductions in morbidity and mortality. In that season, it was thought almost 10 million illnesses were prevented, almost 5 million medical visits, 118,000 hospitalizations, and around 8,000 deaths. And additional multiple studies have demonstrated that vaccinated people who do contract the flu generally experience a milder illness and they recover quicker than those that are unvaccinated. So I think it's important to be honest with patients that the flu vaccine is not a perfect tool. Some years are better than others, but it does remain the best available method for protecting against infection and potential complications. And while it's not nearly as effective as many of our other standard vaccines, we can reassure patients that the flu vaccine is safe, it's well studied, and it is significantly beneficial. Looking particularly at pediatric flu vaccine effectiveness, in these 7 studies, effectiveness ranged from 46 to 78% for hospitalization or ICU admission. In another 15 studies, effectiveness ranged anywhere from 32 to 92% for medically attended flu. So flu vaccines have been around for a long time, with research and surveillance data continuing to support their safety. This slide shows pediatric flu vaccine coverage in the US last season. We saw a decrease compared to previous years in all pediatric age groups, and we really continue to hover below that 70% target set by the Healthy People 2030. Locally here in North Dakota, we see even worse rates. We actually rank 36 out of 50 states for pediatric flu vaccine coverage. So we'll briefly take a knowledge check. You can just answer this question on your own or in your head. So during the last respiratory season in the United States, A, pediatric flu deaths decreased compared to previous years. B, over 200 children died of influenza, marking it the highest toll in over a decade. C, pediatric deaths were minimal and only occurred in kids who had chronic medical conditions. Or D, nearly all the pediatric flu deaths occurred in children who had been fully vaccinated. Hopefully you are thinking B, which is the correct answer. As we said, 275 children died of influenza last season. Okay, that was influenza. We're going to move on to RSV. This is a very common virus. Most babies become infected during their first year of life, around 70%, and nearly every child has seen this virus and been infected by their second birthday. Every year, this remains a common reason for pediatric hospitalization. It's actually the most common reason for US infants to be hospitalized. And we know our youngest babies are the ones at the highest risk. And while being born early or having some sort of chronic disease increases risk, the majority of hospitalizations, almost 80%, occur in healthy term infants with no underlying conditions. Each year in the United States, for children under the age of 5, RSV is estimated to be associated with around 1.5 million visits to the doctor, a little over 500,000 trips to the emergency room, and anywhere from 58 to 80,000 hospitalizations and between 100 to 300 deaths. So what are some RSV prevention tools for kids? Let's look at the 25-26 recommendations. We now have 3 options for infant protection. First is maternal vaccination. So this is recommended during 32 to 36 weeks gestation seasonally. So in most places, it's September through January. And now we have 2 different monoclonal antibody products for infants. Nirsevimab, so same recommendations you saw last season. It's for all babies less than 8 months, and then some older toddlers that remain at increased risk. Who is that? It's anyone 8 to 19 months with chronic lung disease of prematurity, severe immunocompromise, certain CF patients, and particular cardiac conditions fall under there as well. Important to note, though, that included in that high-risk group that second year are American Indian and Alaskan Native children, important for our region. This is because they experience significantly higher rates of severe disease and hospitalization, thought to be associated with social drivers of health. And new to the market is clesrovimab. This is recommended for all infants under the age of 8 months who are entering or born during their first RSV season. So again, just showing you a highlight the timeline. These recommendations are seasonal, so we want babies protected before RSV peaks. Typically, the antibody products are given October to March. RSV season can vary around the country, though. So if you live in Alaska or Florida or outside the continental United States, you'd really want to check of when your RSV season is expected to happen. This is a nice flow chart I like put out by the AAP. I find it helpful clinically. So it kind of starts by ensuring, are you within the right seasonal recommendations? And then it looks at the patient's age. You want to verify if mom did or didn't receive a maternal RSV vaccine. And then it looks at things like weight. It actually ends by telling you the recommended dose for that infant. So that's there for your reference if you find that helpful. A survey conducted among 200 pediatricians and 200 OBGYNs in October of 2024 found that while most pediatricians agreed that nirsevimab was safe and effective, only 77% had ever offered it. Some of the top challenges that they feel like they faced were addressing parental concerns about its safety, knowing whether the mother had received RSV vaccine or not in pregnancy, and then the financial burden with purchasing nirsevimab. Similarly, you can see most OBGYNs agreed that maternal RSV vaccine is safe and effective, but only 63% had offered the vaccine to pregnant patients. In this group, the top challenges reported were, again, about safety and reimbursement, as well as effectiveness. So knowing that healthcare providers are the most trusted resources for patients, I think it's really crucial that we are recommending these prevention options every time to all of our eligible patients. Looking at nirsevimab effectiveness in the pediatric population, so this is for all patients under the age of 24 months, effectiveness ranges anywhere from 64 to 93% for hospitalization, 51 to 91% against ICU admission, and a range of 17 to 89% for medically attended RSV. Clesrovimab is new this season, so we don't have effectiveness data, but trial efficacy data did show that this is almost 91% effective against hospitalization and around 60% effective for medically attended RSV. For the maternal RSV vaccine, data from phase 3 clinical trials showed an almost 82% reduction in severe lower respiratory tract disease from RSV within 3 months of birth, and then nearly 70% reduction out to 6 months. And we know that that first 6 months of an infant's life is when they are at the highest risk for RSV. When we look at the safety data for the maternal RSV vaccine, this has been something talked about. Overall, it's reassuring. The most common side effects are kind of what we'd expect from any vaccine. So things like soreness at the injection site, headache, muscle aches, and nausea. One question that came up during the clinical trials was whether this vaccine might be linked to an increased risk of preterm birth. So in the trial, the rate of preterm birth was slightly higher in the vaccine group, about 5.7%, when compared to the 4.7% in the placebo group. That difference was small, as you can see, and it was actually not statistically significant. Most of the cases were late preterm. Importantly, there was no signal for very early preterm births, and follow-up studies have not confirmed a causal link in this. So while a causal relationship can't be fully ruled out, the evidence we have does make it seem unlikely. But because of this theoretical concern about preterm birth, this is why the vaccine is only recommended to be given later in pregnancy during that 32 to 36 week time period. That window ensures that infants still get the full benefit of maternal antibodies, but minimizes any potential risk. There's also been discussion about hypertensive disorders of pregnancy. There was some early data to suggest a possible slight increase, but this may be related to confounding factors. I would say right now the evidence doesn't really support a clear connection for that. You may have also heard about Guillain-Barré syndrome or GBS. The FDA did add a warning about a possible risk of this in older adults. So this was seen for people 65 and up. It was not a signal seen in pregnant individuals. So there's no evidence of any increased risk during pregnancy. This is just a nice comparison chart of the available RSV prevention products. So some advantages of the maternal vaccine would include protection for infants right away in that newborn period, of course, less pokes for baby, and then this can be administered with any other recommended prenatal vaccines. Some disadvantages are the potential for reduced protection in certain circumstances. So maybe mom doesn't mount enough antibody, or there's issues in the placental transfer of that antibody. Maybe baby is born too soon after the vaccine is given. And then there's a potential, like we said, theoretical risk of hypertension. Advantages for RSV immunization in the infant would include things like a more slowly waning protection with those antibodies. You eliminate the placental transfer step, so baby's directly receiving those antibodies, and of course, no risk to the pregnancy. Some disadvantages are the injection itself, and then any delays or access issues that might leave infants at risk for RSV if they aren't getting it right away. So, a question we get sometimes at Siri: should a pregnant person receive the maternal RSV vaccine during pregnancy this season if they already got that vaccine during a pregnancy in a previous season? For now, the answer to that is no. You only need that during one pregnancy. And so, in this instance, we would recommend the infant receive an antibody product. RSV associated hospitalizations went down last season when compared to previous season when we didn't have prevention products, which is encouraging. And the greatest reduction were in those 0 to 2 month olds, which we know are the group at highest risk for hospitalization and severe outcomes. Encouragingly, we saw rates of maternal RSV vaccine increase last year compared to the year before, going from almost 18% to a 38.5% uptake. Hopefully, we'll see this trend continue. There are less logistical and availability issues anticipated this season, and I also think overall confidence is increasing in these products as well. Recent survey data tells us most mothers intend to either receive the maternal RSV vaccine or have their infant receive nirsevimab. All right, our second knowledge check. Which of the following infants is eligible to receive a single dose of clesrovimab for protection against RSV during their first RSV season, according to current public health guidance? A 10-month-old infant who received maternal RSV vaccination during pregnancy and is entering their second RSV season, a 12-month-old infant entering their first RSV season, a 6-month-old infant born during RSV season whose mother did not receive RSV vaccine during pregnancy, or D, a 4-month-old infant born to a mother who received maternal vaccination 20 days before birth. Okay, so that answer is C. All those other scenarios would not meet the current recommended criteria for administering clesrovimab. Finally, we will discuss COVID-19. Unfortunately, COVID continues to bring children into the hospital. Outcomes among those hospitalized can be severe, with 1 in 4 admitted to the ICU. Deaths from COVID-19 do continue to occur among our infants and children. And it's actually thought that death certificate data might undercount these. The majority of kids hospitalized are not up to date with COVID-19 vaccination. Most pediatric hospitalizations occur in children under the age of 2 who have no underlying medical conditions. Even for ICU admission, 53% are in otherwise healthy kids. This was actually a little bit different data from a recent study published in Pediatrics that looked at COVID-19 hospitalizations in kids, and it also looked at the factors that put them at higher risk for severe illness. So these researchers focused on kids 6 months and older. They analyzed data from October of 2022 through April of last year. So out of nearly 2,500 children that were hospitalized for COVID, about 45% were young, between 6 months and 23 months old. One striking finding was, though, that most of these kids, around 59%, did have at least one underlying medical condition. And that really varied by age. So for the youngest age group, around 42% had an underlying condition, but by the time the kids were a little bit older, 5 to 17, that number jumped to over 75%. Vaccination rates among hospitalized children were very low. Less than 4% in this study were up to date with recommended COVID vaccines. When they looked specifically at what factors were linked to severe disease, so things like needing ICU care, mechanical ventilation, or even in hospital death, they did find some patterns. So in those younger kids, 6 to 23 months, having chronic lung or heart disease increased the risk of severe illness. For kids 2 years and older, chronic lung disease, diabetes, and neurologic disorders were the things associated with severe outcomes. So the takeaway, it's kind of a busy slide, but most hospitalized children had at least one underlying condition and very few were fully vaccinated. So I think this study reinforces the importance of COVID-19 vaccination, especially for kids who have at least one high-risk condition, but it could help prevent hospitalization and severe illness. Let's take a look at this chart. This is showing the total number of COVID-19 and influenza associated deaths among US children from July of 2024 through June of 25. What we see here is that influenza caused the largest number of pediatric deaths overall. I told you it was an especially bad season, but especially in older children, aged 5 to 17 years, where 142 flu deaths were reported compared to only 29 from COVID. If we focus on the youngest children under 2, the picture looks very different. In this group, COVID-19 was responsible for 45 deaths, actually slightly more than influenza, which caused 44. And then for toddlers 2 to 4, COVID did still contribute 16 deaths compared to 42 from flu. So while influenza was the bigger driver of pediatric mortality this past year, I think it's important to remember that COVID-19 remains a real concern, particularly for infants and toddlers. Okay, a quick note about long-term effects of COVID. Defining the burden of long COVID in kids has been nuanced and challenging. Some of this difficulty is similar to what we see in adults: inconsistent definitions, studies that lack comparison groups, a lack of specific diagnostic tests, or even in some cases, diagnostic criteria. Of course, kids add further challenges as they can't really tell us what's wrong or what they're feeling always. But a vast array of symptoms have been reported in children involving almost every body symptom system, and these can vary really widely. So the best quality pediatric studies that we have to date really show a wide range of long COVID prevalence. We tried to group them here in a chart. I think some of these variations is largely driven by study design and follow-up length. But large retrospective cohorts have estimated very low prevalence, so somewhere between 1 to 4%, highlighting really the rarity of persistent symptoms in these big data sets. National and multi-center prospective cohorts report higher rates, so anywhere from 7 to 16%, especially at earlier time points, though prevalence decreases with longer follow-up. So together, these findings suggest, most children recover, but a meaningful subset, likely anywhere between 1 to 10%, depending on method, experience prolonged symptoms that impact health and quality of life for our kids. This study set out to answer an important question: are children and adolescents more likely to develop type 2 diabetes after COVID-19 compared with other respiratory infection? We've seen some evidence of this association in adult literature, but pediatric data have been kind of limited. So this was a retrospective cohort. It used a very large EHR database and analyzed over 613 pediatric patients. And they found kids who had no prior history of diabetes. About half had had COVID-19 and the other half had had some other respiratory viral infection. The groups were then matched on demographics and they were followed for 6 months to track new diagnosis of type 2 diabetes. And the results were fairly clear. Children who had had COVID-19 were significantly more likely to be diagnosed with type 2 diabetes compared to those with other respiratory infections. So you can see at 1 month, the risk was about 55% higher. At 3 months, it remained nearly 48% higher. And even out to 6 months, the risk was still 58% higher. So this wasn't just a short-term signal. It persisted across the full follow-up period for this study. I think this risk is especially elevated, or excuse me, I know this risk was especially elevated in certain groups. For overweight and obese children, they found the likelihood was 2 times higher. And for those hospitalized with COVID-19, the risk was even higher, up to 3 times higher, when compared to kids hospitalized for other viral infections. So it's important to note this was an observational study, right? It can't prove causality, and it remains unclear whether these new onset diabetes cases will persist long term or maybe they'll resolve over time. We will need more research to answer some of those questions and others, but I do think it's an important consideration for pediatric care and long-term follow-up after infection. MIS-C, this was one of the most concerning complications of COVID in children early in the pandemic. And this is an uncommon but severe hyperinflammatory illness that typically occurs 2 to 6 weeks after a SARS-CoV-2 infection. Its presentation really overlaps with other conditions, and risk factors for severity seem to differ by patient. At its peak, though, in 2020-21, we were kind of seeing MIS-C at much higher rates, with many children requiring intensive care. By 2023, the incidence has fortunately dropped dramatically to now it's about 0.1 cases per million children per month in the United States. So that really represents a decline of more than 95% from the peak. Also, the proportion of total cases as well as disease severity has seemed to decrease over time with sequential SARS-CoV-2 variants. So we know about 58% occurred pre-Delta, whereas 16% have occurred during the Omicron predominant phase. But importantly, even though MIS-C is rare now, it continues to be severe when it does happen. About half the cases still require ICU care. And I would point out that vaccination has made a big difference. So most recent MIS-C cases are in unvaccinated children or in previously vaccinated kids whose protection had waned in some way. Okay, so let's talk a little bit about COVID-19 vaccine for kids. These are some key details of the 25-26 formulation. This vaccine is going to target JN1 lineage, which caused a global wave of infections in early 2025. The specific LP81 substrain was chosen because it was the dominant circulating variant at the time. This vaccine is going to be monovalent, meaning it's designed to protect against only one type of viral strain. Previous versions of the COVID vaccine were bivalent, so it covered both the original virus and an earlier Omicron strain. These will continue to be monitored for safety and effectiveness throughout the season. And then a quick note about FDA approval. So each respiratory virus season, as we kind of said, the FDA approves updated seasonal COVID vaccines based on their determination of its benefits outweighing any known or potential risk for the intended population. The FDA approved drug label includes the indications for use, including the disease and the population. So it's typical for this to occur at the end of August when the FDA also inspects products to ensure that they're safe for use. On August 27th of this year, so very recently, the FDA approved the 25-26 COVID-19 vaccines with indications only for adults 65 and up and people 6 months to 64 years with conditions that put them at higher risk for severe illness. So this was a real narrowing of the label from previous years where it was approved for everyone over the age of 6 months. And then regarding FDA licensing, authorizations cover the Moderna vaccine for people ages 6 months and older, Pfizer for people 5 and older, and Novavax for those 12 and up. Another chart here for your reference, but multiple medical organizations have come out recommending COVID vaccination for all children under 2, plus children at high risk, or they say anyone who desires protection. But you can see the FDA label says for ages 6 months to 17 years with 1 or more high-risk conditions. CDC removed its recommendation for healthy children under 2. So it is likely insurance companies will cover off-label use for healthy kids. Similarly, for pregnant women, ACOG and others have recommended this at any time during pregnancy, while the CDC does not. This will be covered by insurance, though, because pregnancy is considered an at-risk or high-risk condition by the FDA. All other adults we're sort of still waiting on. As previously discussed, the ACIP has not voted on this season's COVID vaccine recommendations, though historically they have generally aligned their recommendation with FDA approval decisions. So last year, the ACIP recommendation was made in June, and clinical guidance was issued by the CDC in late August. We don't have that. We're still sort of waiting on that. The Infectious Disease Society of America has said that FDA's narrowed labeling indications ignore science and put millions of American lives at risk. So if you're under 65 and wondering what qualifies as high risk isn't defined by the FDA. It defaults to CDC's list, which includes many adults actually in the United States. So pregnancy, diabetes, disability, overweight and obesity, cancer, mental health conditions. It could change at the upcoming ACIP meeting, but for now, this is what stands. And people of all ages, including children and teens, can get very sick, but we especially know those with underlying medical conditions. So this would include things like medical complexity, genetic, neurologic, or metabolic conditions, congenital heart disease, and like adults, kids who have obesity, diabetes, asthma, or chronic lung disease, sickle cell, or anyone who's immunocompromised is especially at increased risk for getting very sick from COVID-19. Health insurance companies are required to cover vaccines listed in the CDC immunization schedule, including those with shared clinical decision-making recommendations. So payers also can choose to cover broader uses than what the ACIP and CDC recommend, including off-label use. The AAP has been talking to payers and strongly encouraging them to cover its and other medical groups' recommendations. This is a quote put out by this AHIP, which is a trade association that represents multiple health insurance companies and health insurance industry. It says it's reviewing the FDA's authorizations with its members and watching closely for ACIP and CDC recommendations. When we look at COVID-19 vaccine recommendations across other developed nations, the US really stands out right now for having a much more restrictive program. And it's notable in its shift from earlier in the pandemic when vaccines were recommended more broadly. Canada has taken a different approach. Their fall program makes doses available to everyone 6 months and older. It does make a clear emphasis on priority groups, though, so older adults, people with underlying condition, pregnant people, and healthcare workers. The UK's fall 2025 program is actually the narrowest of all. It recommended boosters only for adults 75 and up, or people living in long-term care facilities, or anyone 6 months and older who's immunosuppressed. So that really means most healthy adults under 75 and nearly all kids in the US or UK would not be included this season. Australia falls somewhere between these approaches. So they recommend annual doses for adults 65 to 74 with a stronger guidance for those 75 and up. They actually advise that that group get a dose every 6 months. For younger adults and children, vaccines are only recommended if they have medical risk factors, and pregnant people are included in their priority group as well. A quick note regarding physician liability. So clinicians prescribing the COVID vaccine, even off-label, have 2 layers of protection: malpractice coverage and provisions under the PrEP Act. So the PrEP Act provides broad immunity from any state or federal liability, although some court decisions have narrowed the protection and immunity is not a guarantee. But under the principles of malpractice law, a plaintiff filing a lawsuit would have to show that the physician deviated from the standard of care, which is not determined by FDA or ACIP alone. So following AAP guidance would be strong defense that the physician acted within acceptable standards. And we know physicians commonly use off-label prescribing. It's estimated that around 1 in 5 prescriptions in the United States are meant for off-label use. Oh, I want to make a quick note about pharmacies here. Sorry. Liability protection for pharmacies, though, using COVID vaccines off-label is a little more limited than physicians, and this does vary by state. There is a broad concern right now, though, that our pharmacists and their limited ability to do this is going to impact vaccine administration. In past years, pharmacists have administered around 90% of all of our COVID-19 vaccines. But pharmacists can still administer COVID-19 vaccine off-label using either a collaborative agreement or a prescription or an order from a practitioner. According to preliminary data presented to that vaccine integrity group, pediatric COVID vaccine effectiveness was estimated to be about 65% for hospitalization or ED visits. What about the question of vaccine as a means to prevent or even treat long COVID? This case controls study found that vaccine was associated with a 57% decreased odds of having one or more post-COVID symptoms and 73% decrease of two or more. When we look at the overall safety of COVID vaccines in kids, the evidence is very reassuring. These vaccines have been studied in clinical trials and then monitored extensively in our real world use for them. So things like VAERS and Vaccine Safety Data Link, VSafe, and even international registries. So together, these monitoring systems cover millions of doses given to children worldwide, and they consistently show that these vaccines are safe. Most common side effects are similar to our other routine vaccines: sore arms, some fatigue, maybe a low-grade fever. These reactions are usually mild and self-limiting. And then importantly, no new or unexpected safety concerns have been identified in the pediatric age groups since these vaccines have been rolled out. A note about myocarditis: there was an earlier concern about this. Data are consistent with prior literature and emerging adult literature, actually, that demonstrating a baseline incidence of myocarditis following COVID-19 vaccine. The highest incidence occurs after 2 doses in a primary series, and lower incidence with subsequent booster doses. In kids and adolescents, the likelihood of getting myocarditis following an actual COVID-19 infection is significantly higher, and the condition is notably more severe compared to the more rare and generally milder cases observed following COVID vaccination. And we have extensive and recent data, including a randomized controlled trial, showing that co-administration of a COVID vaccine with other vaccines, particularly a seasonal flu shot, is safe. So given this reassuring vaccine safety and effectiveness, COVID vaccine rates remain low for children, well below 20% for all age groups in the United States. Some poll data from April of this year showed that over half of parents definitely or probably won't get their child a COVID vaccine. There's a similar percentage at the other end of the spectrum, those that definitely intend to or maybe already have got a vaccine. And then around 28% of people remain unsure or state that they would probably get a vaccine. So I think focusing on this, what we call a movable middle, may be our best bet for increasing pediatric rates. Okay, our final knowledge check. True or false? Most children hospitalized for COVID-19 were up to date on their vaccinations. That is false. A couple of just summary slides here. I've got about 5 minutes left. So just in summary, I know that was a lot of information. The major fall pediatric respiratory viruses this season, so flu, RSV, and COVID-19. I hope we've shown you they each bring their own challenges, but we also have opportunities for prevention. So for influenza, last year's flu season was especially severe for children, pediatric deaths hitting a record high of 275. Everyone 6 months and older is recommended to get an annual flu shot. The vaccine proved effective, substantially reducing healthcare visits and hospitalizations. Unfortunately, vaccination coverage continues to decline, and last season had the lowest rates in more than a decade. RSV remains the most common reason infants are hospitalized. For the first time, we now have 3 prevention strategies: 2 monoclonal antibody products for infants and the maternal RSV vaccine. All 3 are safe and effective. Antibodies are ideally given at birth or within the first week of life, and the maternal vaccine is given seasonally between 32 to 36 weeks gestation. COVID-19 continues to disproportionately impact infants and toddlers. Most hospitalized or ICU admitted children had no underlying condition, showing that risk applies kind of broadly. Recommendations from CDC and AAP differ, which complicates access. Pediatric vaccines work, reducing hospitalization, long COVID, and death, but coverage and vaccine intent remain low. So overall, flu remains severe and under-vaccinated. RSV has strong preventative tools, but needs consistent uptake. And COVID-19 continues to threaten our youngest children, but suffers from very low vaccination rates and conflicting guidance. Here's that fall and winter immunization guide again for you in the interest of time. I'll go to this next slide. This is a little bit expansion on that about how well do these work, what products are available, and then when should patients get this. So please utilize these if this is helpful for you. With that, I will turn it back over to you, Maeve.
So we did have a couple questions here. So first, someone asked, I just had a newborn on August 20th and was unable to get the RSV vaccine while pregnant, as the doctor stated it was not within the time period. How do I protect my 1-month-old as she is not able to get vaccinated for flu or RSV or COVID?
Yeah, great question. I was going to maybe go back to that timeline slide we had. We would recommend that the infant receive one of the monoclonal antibody products. So I'm just trying to look at her specific example. So she was pregnant during August. Yeah, so unfortunately, probably wouldn't have hit either of those. But I would say as soon as either nirsevimab or clesrovimab is available, that could be recommended for her infant.
Wonderful. Thank you. And then I guess just another question. So with all of these changing recommendations, it can be pretty confusing for patients. So how would you recommend providers kind of navigate these conversations with all these changes, maybe particularly for like COVID vaccines for kids 2 years and older?
Yeah, it's a great question, and it might depend on the provider, but as we've shown you in multiple poll data, patients do trust their nurses, their pharmacists, and particularly their individual doctor. So I think just being realistic with patients about where you're getting your information as a provider. This is a changing landscape, being influenced by politicization and polarization, I think, as we've seen. And so I think it's safe to say, groups like the American Academy of Pediatrics, ACOG, these are made up of all physicians and represent our field and our expertise. And so groups like the AAP in particular have made vaccine recommendations since the 1930s, I believe. So this is not new. And we've always followed groups like this. This is just the first year that it's not been in alignment with some of the things we're seeing from federal agencies. So maybe reinforcing that you aren't recommending anything new or different. You've kind of always followed groups like AAP or ACOG, or even this vaccine integrity group, and vetting its members and things like that. I think just being honest and transparent with decision making.
Awesome. Thank you. So I guess we'll just wrap up. We are at 1 o'clock. So I just want to thank you, Dr. Newman, again for your presentation. And thank you everyone for attending. And we'll look forward to seeing you all at our next webinar.
Thank you so much.